Welcome to Moving Medicine, a podcast by the American Medical Association. A 2023 AMA report showed that even though opioid prescriptions decreased for the 13th consecutive year, overdoses and deaths related to illicitly manufactured fentanyl, methamphetamine, and cocaine increased. It's clear a one-size-fits-all approach to pain management isn't a prudent way to manage patient care. In part one of this series, Dr. Michael Sook, chair of the AMA Board of Trustees, is joined by three leaders of the Federation of State Medical Boards to discuss policy shifts and its revised recommendations for opioids and pain care. Here's Dr. Sook.
Hello, and thank you for joining us this afternoon. I'm Dr. Michael Sook, chair of the American Medical Association. As an orthopedic surgeon and one specializing in orthopedic trauma, I deal with pain and patients who are suffering from conditions that cause them pain all the time. And we also try, and within my specialty, to try to engage patients in ways that can avoid surgery and oftentimes in different ways to mitigate their pain symptoms. Sometimes this includes things like physical therapy or cognitive behavioral therapy, and oftentimes medication as well. And sometimes those therapies work great on their own or in combination. Sometimes opioid therapy is helpful. And if surgery is needed, some or all of those therapies might be needed. How do I know what to do? Well, it depends on the needs of each patient. It depends on the evidence and my own clinical experience. And sometimes it depends on the patient's insurance. The one thing that it does not and should not be based on is government interference or arbitrary restrictions. That might seem obvious, but even though physicians have reduced opioid prescribing by more than 50% over the last decade, health insurance companies have not increased access to affordable non-opioid alternatives. Even though the CDC now opposes numeric limits on prescriptions, nearly 40 states have laws that restrict access to opioid therapy. These restrictions have harmed patients with chronic pain, those with cancer and in hospice, and those who have sickle cell disease. The AMA has called for balance and individualized care decisions, and we have supported efforts in states and in Congress for such bills such as the No Pain Act, which requires Medicare to pay for non-opioid alternatives. It's disappointing that it takes legislative advocacy to force payers to increase pain care options for patients, but the AMA will never stop fighting for these patients and access to affordable care options. And we are also thankful for the leadership of the Federation of State Medical Boards to recognize the need for that balance as well. As a surgeon, these guidelines reflect how I try to practice, treat every patient as an individual, engage in shared decision-making, and about the benefits and risks of all treatments, and work together to maintain or improve function and outcomes. Joining me today are three physicians who will detail just how the FSMB accomplished this. Humayun Chaudhry, DO, President and CEO of the Federation of State Medical Boards. Sarvam TerKonda, MD, past chair, Federation of State Medical Boards. Sherif Zaafran, MD, board member, Federation of State Medical Boards. So I'm going to get started right away and just jump in with a couple of comments and questions. Dr. TerKonda, you were chair of the work group developing these new recommendations. Can you share with us why these new updates were needed?
Well, thank you, Dr. Sook. In April of 2024, the Federation of State Medical Boards, House of Delegates, adopted this guidance document called Strategies for Prescribing Opioids for the Management of Pain. And there were essentially four reasons why we needed this update. Number one, the new emerging evidence. Since the adoption of our previous guidelines in 2017, new evidence had emerged about the risks and the benefits of prescribing opioid therapy. This included the value of risk mitigation strategies such as tapering and discontinuation to limit patient harm. The second reason was the accelerating opioid epidemic we all were exposed to. Despite a decrease in the overall opioid prescriptions by over 44% from 2011 to 2020, the overdose deaths continued to rise to over 107,000 in 2022. Obviously, we know this was largely attributed to illicit and synthetic opioids, but this prompted a shift in our strategies to treat opioids. The third reason was the prevalence of chronic pain. Unfortunately, in the United States, chronic pain remains a significant public health hazard, with 1 in 5 adults in the United States experiencing it. And the fourth reason was we had inadequate pain treatment. Certain patient groups, including older adults and those with cognitive impairments, may be at high risk for pain, but had inadequate pain control. The FSME recognized that the need for the updates was to really advance the current pain care and improve safe opioid prescribing. So those were really the overall reasons for updates.
Thanks for that. And, it's interesting because so much of the discussion of treating patients with pain, especially among policymakers, has been really focused on a yes or no. Do we prescribe? Don't we prescribe? Or how much do we prescribe? How would you describe these recommendations as different from just a pure quantity type of approach?
Well, you're right. The focus has shifted from this binary yes or no approach to a more kind of a nuanced understanding of pain management that really emphasizes individualized care. And I think the current guidelines that we just had this past year, advocate for a more patient-centered approach, emphasizing that decisions regarding opioid prescriptions should be made in a collaborative manner between the physicians or clinicians and the patients. This is really based upon the individual needs and circumstances. We also realized there was a need for a more comprehensive treatment plan, including non-opioid and non-pharmacologic therapies. And we wanted to also emphasize the need for a better method for monitoring and providing risk assessment to the patient. So those are really the basic reasons that we've seen this shift from this yes or no approach to opioid therapy to a more nuanced approach.
No, it's very helpful, and thanks for sharing that information. So, a member of the work group, and you are also a member of the Texas Medical Board. What's your perspective on why these recommendations are important, and why are they needed now?
Oh, thank you for inviting me and being part of this panel. Appreciate the AMA helping take the lead on a very important issue. So as president of the Texas Medical Board, one of the things that, of course, I'm concerned about is the balanced approach of making sure that we're regulating the inappropriate use of opioids while at the same time not disadvantaging patients who need to appropriately be treated for opioids or with opioids for chronic pain or for any type of pain for that matter. One of the biggest concerns that I have is patients being moved from a regulated environment into an unregulated environment. And if you look at most overdose deaths that are out there, it actually happens in the unregulated environment where patients are still seeking treatment for pain that they may not be able to access from their physicians. And in that unregulated environment, they may think that they're taking an oxycodone tablet, but as we know, in many instances, these may be laced with things like fentanyl or other entities that cause overdose deaths. So one of the biggest things that we've been focusing on is making sure that patients have appropriate access to care and that physicians don't feel like they're being targeted when appropriately managing and treating pain. And that took on quite a bit of effort. We had to make sure that the legislature was going to pass laws that were not going to unintentionally create an environment where patients were being pushed into an unregulated environment. And at the same time, we needed to look and create rules to make sure that physicians felt that they were, if doing the right thing based on the guidelines that we have here, were not going to be targeted. And a little bit later on, we can talk about some of the specific things and how we did that in the Texas Medical Board.
No, I think that's great additional information. Your perspective as someone who's on the state medical board, I think, is really important. Going with that theme, how can medical boards and state medical associations together work to ensure to find the balance of caring for patients with pain and the fear that physicians have for treating them in a manner that may make them a target? And more importantly, how do we not overregulate and provide appropriate guidelines?
Yeah. So as I had kind of briefly mentioned earlier on, there is the first step of making sure that legislators don't unintentionally with the goal of appropriately wanting to make sure that they address the opioid epidemic, are not passing rules and laws that can actually have those unintended effects. So we actually worked with the state legislature several years ago to pass some laws that actually gave the medical board some latitude in helping create rules that help govern how we define acute pain, chronic pain, et cetera, and how we govern and regulate that process. because as we know, it's not a one size fits all. And we've got to make sure that we have that flexibility in managing the process. The other thing that we did is I put together a task force and a stakeholder group that included the Texas Medical Association, the Texas Pain Society, insurers in the state of Texas, because the payers, of course, play a big role in that. This was before the No Pain Act, where the federal government actually mandated for the payment of non-opioid modalities. And actually, we had patients involved, or the public involved in the stakeholder group. And the idea behind this was to look at solutions, not identifying problems, but we wanted to make sure that we weren't just hearing complaints, but we were going to come up with ideas of how to actually address this. And after about a year and a half of having several stakeholder meetings, we came up with a gold rule in the state of Texas. And that rule, which in Texas, a rule from the medical board has the force of law on it, created a mechanism where if a group of providers that included a physician, which may have been a primary care physician, along with a consulting chronic pain physician, along with other entities like behavioral therapists and other types of therapists that would help in a multimodal type of approach, not only multimodal but multidisciplinary. If they had that type of structure in place and actually operated a proper pain management clinic, which is overseen by the medical board, then we would do something called a gold rule pass, which essentially meant that after the initial audit, we would hold them harmless from any type of audit for the next 5 years, so long as they actually didn't have a formal complaint that came along the way. And the reason we did that is we wanted to make sure that, number one, we empowered physicians who are in any type of setting, whether it be rural, urban, suburban, or what have you, to be able to coordinate with other specialists using telehealth or telemedicine in a virtual manner and in a collaborative manner, and with that be able to actually treat a chronic pain patient in a manner that follows these guidelines. Again, multimodal, multidisciplinary type approach. We think that's working. We've been telegraphing that to our physicians so that we can encourage them to be part of this process. And so far, I think it's been working. The other thing that we've been doing is working with the pharmacy board, making sure that they don't arbitrarily just start changing medications, especially opioids, without consulting with the physicians. Because again, if you limit what a patient can take, especially a chronic pain patient, again, that forces them to potentially go into that unregulated environment and kind of defeat the purpose of a lot of what we're doing. So that's been our starting process. I think it's been working, but it has been a collaborative effort with all the different stakeholders in the medical community as well as in the non-medical community.
Oh, that's very helpful. And your experience certainly in Texas, I think, is going to educate many others, and with the experience that you have there. Dr. Chaudhry, you're the president and CEO currently of the FSMB, and so maybe you can talk a little bit about how FSMB is helping to implement some of these recommendations.
Well, thank you very much, Dr. Sook, and thank you to the AMA for bringing my colleagues and I together. It's an important topic, as you know, and it's a big problem in our nation. So I think it's important to know that the FSMB, the Federation of State Medical Boards, our role is to provide guidance and resources and to share best practices with our state medical licensing boards. And 2 years before this policy was adopted, actually, Dr. TerKonda gets the credit. He was the chair of the FSMB and felt that we needed to review our policies. Our last policy was adopted in 2017, 8 years before, 7 years before. So we took 2 years to thoughtfully put this together. We included state medical board representatives as well as colleagues from many other organizations, including the AMA. And that was important because when it was ultimately presented to our House of Delegates earlier this year, it was adopted. And there was a lot of good discussion, good feedback. But ultimately, where the state boards are now is they're reviewing this document and considering how to adopt and or adapt the document for their use.
I appreciate that additional information. It's good that there's forward progress. Let me just ask you, in addition to the areas highlighted by Drs. TerKonda and Zaafran, Why is it important for physicians and medical societies to read the recommendations in depth? And how else can they work effectively with their state medical boards to help implement some of these recommendations?
Well, that's a great question, Dr. Sok. I think any physician would be forgiven for thinking that a policy that comes out of the Federation of State Medical Boards might be a policy for state licensing boards. But actually, if you read the document, it's not overly long, but it's also with the readership of the practicing clinician and physician in mind. So there are lots of recommendations in there about how to thoughtfully consider patients who come in with pain. It doesn't mean that you don't use opioids. It means you thoughtfully consider non-pharmacological approaches when appropriate. And when you think that opioids are appropriate, that you consider the past history and the context. And I think that kind of review and reminder, I think, would be helpful to any physician, not just those who engage in pain management, to understand what the state boards are thinking. And, as I said, a number of the state boards are in the process of reviewing the document. I think every practicing physician, whether or not they prescribe opioids, needs to know what their state boards are thinking, because it's an issue where there has been some updated understanding and research that Dr. TerKonda and Dr. Zaafran alluded to, which informed what the policy ultimately says.
Medicine doesn't stand still, and neither do we. AMA members don't just keep up with medicine, they shape its future. Help move medicine, join the movement. Visit ama-assn.org/movingmedicine.
No, thank you for that. We have, and appreciate the opening comments and the indulgence of my initial set of questions here. Maybe you could talk about some of the methods that are used successfully to coordinate pain management between primary care specialists and ED physicians. Anything from your experience where you've seen a successful model to try to coordinate that care?
So, Dr. Sirka, I'm like you. I'm a surgeon practicing. So, I think as a clinician, we need to take a holistic view of the patients. We may have our specialties, but we need to be able to recognize anyone that requires pain management therapy. And that means reaching out to the appropriate multidisciplinary approach. So, as we said, we want to really understand pain and how to manage pain, not in our own specialty, but in general. So, the current guidelines really advocated for a more collaborative approach between the care team and that patient. And I think giving this holistic view provides access to the appropriate modalities, whether it's opioid therapy or non-opioid therapy, non-pharmacologic therapy, making sure there's behavioral modifications that are appropriate for the patient. So I think having that understanding and being able to refer that patient appropriately is important. And I think that's where the guidelines come in for someone such as us who are surgeons. We may not deal with chronic pain, but we have that acute pain knowledge. But when we see those patients that need further help, we can get them to the appropriate specialists.
I appreciate that. Yeah, and I agree with you. I think the coordination of care is key. New modalities and new pathways, I think, will ultimately start to come out of these multimodal approaches that require multi-specialty inputs. Dr. Chaudhry, let me ask you a question about just populations in general. What are the concerns of populations who suffered pain management inequities addressed with some of these new rules? It's an equity question.
Absolutely, Dr. Sok. In fact, I think Dr. TerKonda touched on that a little bit in his remarks. While the opioid epidemic has evolved, as we all know, it's no longer just overprescribing or inappropriate prescribing of prescription opioids, long-acting and extended release. It's also illicit and synthetic opioids that are out there as well. But prescribing is still an important component. And so part of the guidelines, what they try to do is to make sure that anyone considering opioids be aware that the research shows that there is a inequity, and minoritized communities in particular have suffered, not only in related to prescribing, but also in relation to pain management. And so that is a key component of this. We benefited on the work group, I should say, by not only having colleagues from the AMA and the AOA, but also from the CDC, input from SAMHSA, the American Society of Addiction Medicine. Again, a lot has happened in the last several years that has better informed our thinking. And that's actually another reason why physicians who are out there prescribing or dealing with patients with pain may want to look at our document to better understand the current thinking of experts from around the world and around the country as they try to manage this.
Thanks. And Sherif, let me ask you a question. Going back a little bit to our conversation with Sarv, in your experience, what do you think is the best approach to shared decision making when it comes to pain management? What are your thoughts on that?
Well, I mean, again, it's a matter of getting the stakeholders who are involved actually helping to manage that patient's pain. Right now we have a system or a mechanism where primary care physicians feel that they are the pain physicians of many of those patients, and they are not equipped or not necessarily feel like they're equipped, whether it's by compensation for time or for some of the modalities that are out there to help manage patients' pain. You have chronic pain physicians who may not necessarily be in areas where some of those patients are. Again, they may be in urban or suburban areas and not necessarily in rural areas. And you also have a finite number of other specialists, behavioral therapists, physical therapy guys that are out there who really should be involved in that process. And you had a mechanism of the multimodal approach, whether it be music therapy, other modalities that were never compensated by insurance. And so, even, up until recently, it's easier to get insurance to pay for opioid medications than it is for them to pay for non-opioid medications. So the first part is, number one, making sure that we have rules and regulations that allow and empower physicians to be able to manage these patients in a way that they feel comfortable in doing so. But the other part is leveraging the technology that's out there, whether it's telehealth or telemedicine, to bring together all these folks, regardless of geography, to help take care of these patients where they're at. To take a chronic pain patient and ask them to drive 100 miles to go see a specialist who can help manage their pain is simply not realistic. So they're going to go to the default, which is the easy way of treating pain, which is by opioids, which is not necessarily the best way of treating it. It's one part of a multimodal approach. The other part that we wanted to do is also retiring physicians. A physician that was managing a patient for chronic pain who all of a sudden retired, and that patient now needs somebody to help manage their pain. And the fear that physicians have in taking on a difficult patient, not difficult because the patient's difficult, but their disease and their illness may have taken years in order to be managed in a way that was appropriate. And all of a sudden, they feel like they may be targeted because they're starting them on medications that would look like it's way beyond what the norm is, however way we define the norm. Making sure that transition is done in a seamless way so that not only insurance companies, but physicians don't tell a patient, by the way, you've been on these medications for years and years and years, but you know what, we're going to have to start you from scratch again. We're going to have to start you from ground zero. And in that transition and starting from ground zero, that patient is going to experience significant discomfort. And they may, again, go to the unregulated environment to bridge that gap. So we've got to make sure that transition for patients when physicians are no longer available for them is something that is done in a seamless way. We've got to create an environment where physicians can collaborate and non-physicians also can collaborate in a way that empowers them to treat those patients in a multimodal and a multidisciplinary way. And as the federal government has just recently done, make sure that the payers are required to pay for best practices, which we are defining again as a multimodal and a multidisciplinary way. All these factors have to come together in a way to do something that is very complex. A lot of the problem that we have is when something is complex and difficult, we try to solve it with an easy answer, and there are no easy answers. It's taken years for us to get to a mechanism that hopefully will start that process, but it is a collaborative effort, and we've got to continue empowering all of us to be able to work together to help manage these patients.
Curated from more than 3,000 major newspapers, magazines, and journals, the AMA Morning Rounds newsletter delivers the top stories in healthcare right to your inbox, Monday through Friday. Subscribe today and check out all the AMA's free newsletters at ama-assn.org/myinbox. That's ama-assn.org/myinbox.
Thanks, Sheriff. Hank, maybe I'll go back to you, and this is maybe something that both you and Sarv can handle together. It sounds like a generic question, but it's a legitimate. What role does the federal government have in regulating pain? We understand what happens in the state licensing boards and state medical, but why the federal government?
Well, they play a critical role in the regulation of a lot of this, but the FSMB itself does not get involved in the reimbursement aspects of it. We're focused on the state licensing aspect. The primary purpose of a state medical board is to protect the public, but also to assure that quality healthcare is delivered. So from our perspective, agencies like the CDC, SAMHSA, DEA play a very important role in sort of giving us the research, giving us information and partnering with us so that we can develop thoughtful guidance. I think from our perspective, that's the key role, but there are obviously other aspects to the management of pain. I think Sherif touched on some of these related to reimbursement, for example, of the non-pharmacological therapies, for example. I mean, it's easy to prescribe, massage treatments or exercise or osteopathic manipulative treatment, but are they covered to the extent that could be helpful? I think in the 7 years since our previous policy, there's been a greater awareness of social determinants of health, and that not everyone has the same ability or insurance coverage to be able to get the care that they need. So what we call for is a more thoughtful response.
Thanks. Sarv, any thoughts on that?
No, I think Hank brought up the most important points, and Sherif also stated that from a federal government standpoint, making sure that all modalities of therapy are available to the patient, not just a single coverage of opioids or making that the easiest option. I mean, there really has to be a more comprehensive approach, and that's what the federal government, I think, can help with, is to provide coverage for that. And as Hank said, FSMB does not get involved in the payment process or any suggestions for payment. We're really looking at licensure and how best practices can be spread among our state boards to the physicians.
I'll also mention, if I may, Dr. Sook, that
Sure.
There's an enforcement piece from the federal side with the DEA. There is a concern about diversion. Where are some of these sources of illicit opioids in particular coming from? So there is an important role for the federal government, I would say, to play to try to mitigate that at that end. What we're focused on, though, is with prescribing and providing care and compassion. Patients with pain deserve as much care and compassion as patients with any other complex medical condition.
Yeah, and sticking with the federal government theme a little bit, I alluded to the No Pain Act, which is due to be enacted or begin to enforce in January 2025. This ultimately has to do with payment for non-opioid alternatives, which, many of us hope will open the door to making much more acceptable, and certainly from a payment perspective, a coverage perspective, patients who want to seek alternatives other than opioids. I'll open it to any of the three of you if you have any thoughts or comments, hope, fear, anything like that associated with what might be turning around the corner here.
Yeah, we used to have an HHS task force on closing the gaps in managing pain. I actually served on that task force several years ago, and one of the recommendations actually was number one, aligning all the different entities from the state lawmakers and federal lawmakers, as well as regulatory agencies and other providers. The key thing with all this, though, is it's not a matter of whether patients want opioids or don't want opioids. It's a matter of how do we help manage their actual true condition of chronic pain, and empowering non-opioid options. Investment and research into it. Looking at the FDA for making sure that these type of modalities are things that are approved. And I know there's a certain number of drugs and other modalities that are non-opioids for managing pain that are out there. Understanding the science around pain and putting some investment and research into it, destigmatizing pain, because the problem with stigmatizing it is that it's sometimes kind of cast aside as something that we should even invest any resources in how to manage. So a big part of that, and as well as patients who have pain, they come and complain of being in pain, and after a while they're looked at as being a problem patient, when in fact they truly have issues, and they may go to other types of things like going into substance use disorders or other things, which kind of make them another target of being stigmatized when they actually do have underlying conditions that need to be managed. Some of them may need psychiatric treatment, which again, there's a lot of payer issues when it comes to paying for psychiatric illnesses, as well as their chronic pain, as well as all their other issues. Making sure that we have that conversation, us as a medical board in the regulatory arena, making sure that we're informing our physicians what are they going to be targeted for in managing and prescribing opioids versus what are they not going to be targeted for as far as following the rules and making sure that they take care of patients appropriately. When I came on the medical board back in 2017, and the initial CDC guidelines talked about 90 MMEs as a guideline for the number of opioids that were being utilized. Unfortunately, the medical board, before I came on, were actually sanctioning physicians for prescribing more than 90 MMEs, even though that's not what the guideline said. The guideline said that for those who are getting more than 90 MMEs, it is better for a primary care physician to consult with a specialist to help manage that pain. So we had to reverse a lot of that. We had to talk to state prosecutors and inform them that, you don't go and just throw an indictment onto a physician for doing what they believed was correct. So that took a lot of education. That whole multifaceted approach in managing a very serious epidemic that's out there is the only way that's going to solve it. Whittling it down to what looks like an easy solution of just punish and try to eliminate the availability of these things really kind of sweeps it under the rug. And again, as I said at the very beginning, forces these patients to go from the regulated environment into the unregulated environment, which again, that's where we're seeing patient deaths. That's where we're seeing sentinel outcomes. And we've got to do everything we can to keep patients in that regulated environment.
Dr. Sukha.
Sherif, go ahead, Sharp, please.
One building on what Dr. Zaafran was saying is one of the other things that we really have to consider is the disparities in access to pain care, especially among our marginalized populations. This involves education and making sure there's recommendations that call for equitable care across all, that consider the social determinants of health, ensuring that all patients have access to the appropriate pain management options, not just the opioids, because we know that in the rural areas, it's easy to get illicit opioids. And we need to make sure that those marginalized populations still have the options of getting non-opioid therapy. I think building on this comprehensive approach of reducing, this pain crisis that we have.
Yeah, I appreciate that. And, it spins on the question a little bit about access and perceptions, not only just from physicians' perspectives, but from patient perspectives. But once again, Hank, Sherif, Sarv, well-esteemed doctors and real advocates in the world of pain management. I want to thank you for joining us.
Don't miss part 2 of this conversation. Subscribe to Moving Medicine today. Thanks for listening.